Hello, I am Professor Arun Chougule. I'll be talking with you today regarding radiation risk due to diagnostic radiological procedure. More so, a recent controversy regarding HRCT during COVID-19. X-rays were discovered on 8th November 1895, and on 23rd November, Professor Wilhelm Conrad Röntgen took the first X-ray of the hand of her wife Anna Bertha Ludwig on 23rd November 1895, and the radiological imaging has started. Before this, there was no imaging procedure and we couldn't see inside the body, and the concept was open and see. The radiological imaging has given us the tool, and the medical diagnosis and treatment has radically changed from open and see to first see with all this radiological procedure, hybrid imaging we have got today, and then decide upon the procedure what you want to do. In 125 years of the radiological procedure, we have come a very, very long way. Initially, people did not know the hazards of radiation, that is X-rays, and immediately after the discovery of X-ray in 1896, the radioactivity was discovered, and the natural radioactivity, and after that the artificial radioactivity is being used hugely, and people were not knowing about the radiation hazard. And there were a lot of martyrs, a lot of radiation hazards, which were known as early as 1902 with induction of cancer due to radiation, death of the young radiologist Ironside Bruce in 1921. 1922, about 100 early radiologists died of radiation-induced cancer. But the awareness grew and radiation protection has started, safe application, safe use, and a number of international organizations are doing this thing. One of them is International Commission on Radiation Protection, ICRP, IAEA, International Agency of Atomic Energy. Then we have ICRU, UNSCARE, and so many agencies internationally functioning. And in India, Atomic Energy Regulatory Board, who is looking after radiological safety and safe application of radiation. Today, if you look at more than 4.5 billion radiological procedures are conducted every year across the world. That means taking the population of the world about 7.5 billion, 4.5 billion means every second person is undergoing a radiological procedure. In addition to that, millions of radiotherapy procedures using very high doses, nuclear medicine procedures are being conducted. So this ionizing radiation is a boon to mankind, and it is revolutionized the medical diagnostic field. And hospital, small or large clinic, you need a radiological diagnostic procedure before, after treatment, deciding upon the protocol and all sorts of things. So there is no dispute about the advantages of the radiological procedure, but it has the associated radiation risk, because ionizing radiation is a double-edged sword. If it is used properly, skillfully, we can draw huge amount of benefits out of it. But if it is used irrationally, unwantedly, then it is going to cause the hazards, and what we call as a radiation hazards, very well known since early the 20th century. They are somatic effects as well as the genetic effects. Somatic effects are those effects which occur in an individual who has been exposed to radiation. But because of the mutation taking place in the cells, that goes to the progeny offsprings, And the largest human data which is exposed to the ionizing radiation is Nagasaki and Hiroshima war. And even the fourth generation of the population who were exposed to the atomic bomb explosion, the fourth generation I'm talking about, are having the radiation hazards result effect that shows the genetic effect. Also, radiation hazards are classified as stochastic and non-stochastic. What do I mean by that thing? Stochastic effects means the effect starts at a very small dose. There is no threshold at all. Whatever the small dose, there is a possibility of the radiation effect or radiation hazards, and it increases as dose increases. These are called as stochastic effect, which has no threshold, and the leukemia and induction of the cancer are stochastic effect. That means there is a risk, whatever small risk there is, that it can induce a cancer. Another is a non-stochastic effect, means there is a threshold. Below that radiation dose, there is no chance of having that effect. What are those things? It's a skin burning, skin effect, cataract, sterility, all these hair loss, all these are non-stochastic effect. It's just one PNS X-ray or the CT scan of skull and head will not induce the cataract, or one CT scan of abdomen and pelvis will not introduce a sterility, because you need certain amount of dose which are much larger than the doses received in the CT scan. Now the question comes, what are the radiation doses received in the radiological procedure, and what are the principle? First and foremost principle is justification. You have to weigh the risk and the benefit out of this radiological investigation. If the patient is going to get benefited out of this investigation by diagnosis of disease or follow-up or treatment protocol, then it is justified. So once it is justified, do it with all optimization. That means we do the radiological procedure by minimal radiation dose, the minimal field use, the minimal number of exposure and size, all those things. And then third is a dose constraint. We keep the radiation doses as low as reasonably possible, reasonably required for getting a diagnostic value, diagnostic image out of that investigation. And to do this thing, though diagnostic reference levels are given, and International Commission on Radiation Protection, IA, and many organizations has brought out for various radiological procedures what should be the diagnostic reference level. Means more than that, if a patient is receiving the dose, that something is wrong with your technique, with machine or the image receptor. Now, if you look at, because I will confine just for the COVID-19 digital radiography, chest radiography, and the CT scan, and is there really any risk of the cancer? Should it be done or should it not be done? If you do a chest X-ray, now chest X-ray over the years, it was film screen combination. Then we have got the CR system. Then we have got a DR system. The X-ray machines have been now very, very nicely having exposure factors, and the things have changed. If we use the film screen combination, the exposure factors for a chest X-ray of an adult PAView, you give about 60 to 70 kVp and about 10 to 16 MAS. But with the digital radiography, this MAS has come down to 4 to 8 MAS, that is a milliampere per second we have to use. So it has reduced almost 1/4 to 1/3 of the what the exposure factor we are using earlier for the conventional radiography. So the doses has come down. from 0.02 milligray. Gray is the radiation dose, the unit, which is defined as 1 joule per kg, the energy is absorbed in 1 kilogram matter. That is called as a 1 gray. I will not go into the details of that thing. And another is used as a dose equivalent to sievert or millisievert. For X-ray, you can say milligray is almost equivalent to millisievert. So in the chest X-ray PA view, the dose varies from 0.01 milligray or millisievert to about 0.04 milligray or millisievert for one chest X-ray. Now, CT scan was discovered way back in 1971 and being used, and now technological revolutions has taken place. Not only the speed, but also the dose reduction is very, very important. Why it is important? Because if you look at the conventional chest CT and what is called as a high resolution CT, where our slice thickness is of the order of 1 to 3 mm, very small slice thickness we use. The dose varies from, for conventional CT scan, I'm talking about 10 to 13 milligray, or what we call as a millisievert, 10 to 15 or 30. Now, with the low dose, high technology, the dose has been brought down to about 4 to 7 millisievert or 4 to 7 milligray. And the DRL value, dose reference, diagnostic reference levels, they are the same. They say about 4 to 10 millisievert or milligray. That should be the range of the HRCT doses. It should not exceed. Now, when we are going to have the low dose, very low dose HRCT, even in the HRCT, what we are going to do for quick diagnosis, it has a great value in COVID-19, and it cannot be disputed at all. But if you see the exposure factor, what we are going to use is 100 kV to 140 kV in between that thing. And what is the MAS we are going to use for the HRCT? It is about 100 to 200 millisievert. And what is the MAS using for the chest X-ray digital radiography? It is 4 to 6 milliampere. So almost 25 to 50 times more MAS we are using for the HRCT. The dose linearly varies with the MAS. Means that chest CT, where we are using 100 to 200 millisievert, 25 to 50 times more MAS, 50 to 100 times more dose, certainly it will deliver. No doubt, absolutely in this case. Now, kV also, if you look at from 60 to 70 kV of the chest X-ray, we are going to about 100 to 140 kV. Now, kV exposure, if you see, exposure is directly proportional to kV raised to 2 or 3. Even to be optimistic, very, very optimistically, even square we take it, for 60 kV and 100 kV, I say, I'm not going to 120 or 140. It will be 3 times more dose. So to be on very conservative, 20 times more MA, 3 to 3.5 times more kV exposure because of the kV. So 75 to 100 times the radiation dose you will receive into HRCT than the chest X-ray. It's absolutely. Even if you are going to use, for example, 120 or 140 kV and maybe 140 or 200 MAs, the dose can go up to 300 to 400 times of the digital radiography chest X-ray. Absolutely no doubt about this thing, that CT are very high radiation dose delivering radiological procedure across the world, and more than 85% of the radiation dose to man-made is because of the diagnostic procedure. Even you are sitting at home or in Jaipur, anywhere, everyone without undergoing any radiological procedure, he gets about 2 to 3 millisievert dose per year because of the natural background radiation. But this is a chronic over the year. As we travel, we go on the height, it will increase more and more. But here in a CT or in a diagnostic procedure, we are giving an acute dose at a time. And what we call in a CT is a CT dose index, CTDI. And when you do your CT, you can ask the technologists, radiologists, that what is my CTDI, what is my dose in that examination, and you can get it from record. I have collected, and we go on keeping collecting the doses during this COVID period. So we have collected about 10 centers from Jaipur and about 10 centers outside the Jaipur, the CT doses for HRCT during COVID-19 pneumonia, whatever you are going to diagnose with that thing. And the doses varied from 4 millisievert to 13.5 millisievert. This is the doses what the chest HRCT has given. And as I told, 0.01 to 0.02 millisievert for a chest X-ray. That means around 200, 300, 4 times, even 600 times more dose than the chest X-ray has been received. Even if you have 256 slice, low dose rate techniques and all those things, you cannot have a chest HRCT less than 3 millisievert dose diagnostic value. So those will definitely be there. Only thing is that once you have justified the benefit you are going to draw from this diagnosis, the benefit you are going to save the life, once you have justified, absolutely you should do. There should not be any in two mind that what is the radiation risk and all. Forget about all those things. It should be done. Question is here, if unjudiciously, unwantedly, just as a screening, if you start doing a CT scan, it's not a blood test or urine test, or it's not a RT-PCR test. It has inbuilt radiation hazard. Now, question of induction of cancer, I told that stochastic effect, there is no threshold for this thing, and induction of leukemia and induction of cancer. Why did I separate this induction, or why world has separated leukemia? Both are cancer, but the induction of a cancer, what is the latent period? For leukemia, earlier it was thought about 5 years it takes after exposure to have a leukemia. But the Fukushima, the nuclear Holocaust, which has happened in Japan in 2011, and people have been followed after that for the radiation, they found this period is as low as 1.5 years. So leukemia can even occur after 1.5 years. And other cancers, which are solid cancer, which we say latent period is 10 to 20 years. So this is how we calculate the risk of the radiation. Here, the question is a diagnosis and treatment where life can be saved and things. Even I will tell you, a pregnant woman met with any accident or any other thing, and we need a CT scan of abdominal pelvis, we will do it if it is justified by taking all precaution, because it is going to save the life. So it is not that there is a radiation risk which should not be done, absolutely not. If had it been that thing, 4.5 billion radiological procedure every year being conducted, that will be all futile exercises. And the frequency is increasing hugely, because the number, if you look at some countries, 1,30,000 to 1,40,000 radiological procedure for 1 lakh population per year, means every person is going more than one radiological procedure. And in India, we are now increasing this possibilities, because we have more than 4,000 CT scan, almost 80,000 X-ray machine. The frequency of radiological procedures is increasing. It was about 15,000 radiological procedure for 1 lakh population 1 year. It has now 25 to 30,000, and it will go on increasing. So a population dose will be there. Now, what is the risk of a cancer? Because as I said, it is the stochastic effect, any dose can do. So evaluation have been done, and we have a lot of data. Major data is the Nagasaki and Hiroshima bomb blast, and they have seen that people in the range from the epicenter long distance who have received 4 to 10 millisievert radiation dose, which is equivalent to CT scan, and what is the induction of cancer in them. Additional data of radiological procedures and all those things. And on these all follow, because we have now 125 years of experience of using the radiation, ionized radiation for peaceful, even destructive purposes, all sort of use applications we have done. And it is observed that if 10,000 people are exposed to 1 millisievert dose, one additional cancer will be induced because of this additional. Once again, I repeat, if 10,000 people get 1 millisievert dose, the additional cancer due to the radiation will be 1. Now, question is here, as the CT scan frequency is increasing, CT scan are very high dose delivering doses, and almost about 100 million CT scans are performed in US every year. The percentage of the CT scan procedure are increasing to 4 to 6% of the total radiological procedure. But however, they contribute for almost 60% of the radiological doses due to all radiological procedures. So they are very high generating. Now, if just as a screening, you start doing the CT scan, large number of population will get 3, 4, 5 millisievert doses, whatever, even low dose if you think of, and 10,000 people exposed to 1 millisievert, 1 additional case, 2 millisievert, 2 cases, 4 millisievert, 4, but it will increase then exponentially. So even if I assume 3 millisievert as the HRCT dose, and if you do 10,000 people, 3 additional cancers are going to be taken. Yes, if it's a life-saving radiological procedure, definitely, but unjudiciously, unwantedly, just screening on the request of the patient, and just, okay, I will go and see, and I have just COVID, and let me see what HRCT and the CT score and all. If you do on this thing, it's a misuse, overuse, and putting your risk. That is the thing. So concept behind this thing is that radiological procedures are very, very important, and they are needed. They are the essential part of the medical diagnosis and treatment evaluation all. They should be done, but they should be done judiciously, with optimization, with the dose constraint, what are there, and there the huge plethora of evidence you will get in the literature. But what I will suggest is you use ICRP report, International Commission on Radiation Protection. Even FDA has classified X-rays as a hazardous material. No doubt about this thing. It's a hazardous material. And therefore, they have also recommended how, when. WHO also has guidelines that during the COVID-19, HRCT should be used, when it should be used. If it is just for screening, should not be used. So all these things taken into account, I think the lot of queries and lot of people have called me when somebody has given the statement that it can have cancers and all those things. The meaning was this: the rampant use for any commercial or whatever purpose of the CT should not be done. It should be judiciously. It is not a simple blood or test. It has inbuilt radiation hazards and the chances of cancer, chances of other effects, and that is well documented. But it should not deter you from not doing the radiological procedure when it is needed and all those things. I hope I tried in a short. There can be a lot of details can be given, but very short details is this, that yes, the HRCT gives very large radiation dose, even though what we call low dose multi-slice, the multi-detector system it cannot be less than 3 millisievert. And as I told, in chest radiography, 0.01 to 0.02 millisievert or milligrade dose. So it's definitely much more. And I told you why more MA, more KV, it is bound to give more doses. But the benefits are much more than the risk. You should do, and it should be done very, very wisely, not as a routine test. Thank you very much for listening this. Any comments, any additional information is needed, I will be happy to